We're now going to look at management of tooth abnormalities in the dog, mainly traumatic abnormalities, but also developmental abnormalities, how to diagnose those and how to treat them. And we see this fairly commonly. You've likely seen this in your practice where we have a fistula somewhere suborbital that results in a purulent discharge and a facial defect. And if you look closely at the picture, you also notice that there are some ocular abnormalities with scleral injection and uveitis secondary to suborbital swelling and extension into and affecting the eye itself. So that can happen and commonly does on the affected side. Resolution may require ocular medical management to manage the uveitis, in addition to removal of what usually is fourth premolar or the offending tooth, and resolution will follow quite rapidly. This is the same patient. You'll notice that there's not much change at all on this tooth. There's no trauma that we can see, but radiographically, you can see that there's a large lucency surrounding the distal root on this fourth premolar, which classically results in that suborbital fistula. Now, these take considerable amount of time to develop, and we know this because quite often we get patients in that have fistulas, and we inquire when the origin of the fracture occurred, if there is a fracture. And owners commonly say, well, that happened when he was a lot younger, or it happened 3 or 4 years ago. So we know that the fistula is one of the end results of the culmination of the tooth dying and or periodontal disease, which we'll see in a moment. That results in the loss of bone around one of the apices or all of the apices of the fourth premolar or other caudal cheek teeth, resulting in breakout past that bone level into the suborbital tissue and consequently fistulation. So the patient suffers for likely years in most cases before the fistula actually manifests itself physically externally. And this is the next progression up from no apparent trauma, and we can probably safely assume that that tooth in the previous example had undergone some type of trauma, and likely blunt trauma, or may have been chronic pulpitis secondary to chewing hard objects throughout its life, to result in that suborbital fistula and periapical lucency that you saw around that distal root. Now, this is where we have dentin exposure, and this is an acute incident that resulted in retention of part of the enamel dentin complex subgingivally where the attachment is still present, but fracture here and exposure of the dentin underneath. You can see that we've got an area here where we see discoloration where the pulp interface is in more of a chronic change that would be consistent with tertiary dentin, and incorporation of the salivary porphyrins into the dentin above the pulp on a slowly worn tooth that's separate and succinct from the fracture line, as you can see here. So this would be more tertiary dentin, where reparative dentin has sealed the dentin from chronic wear and protected this tooth, but the acute exposure here allows microbes into the dentinal tubules and consequently into the pulp cavity and chamber, and will result in this tooth being non-vital.